Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Isabelle Mahé in Paris, France, and Professor Francis Couturaud in Brest, France, in order to discuss the use of reduced dose versus standard dose DOAC treatment for extended anticoagulation in patients after venous thromboembolism based upon their RENOVE and APICAT studies. Dear Francis, thanks for joining us tonight for the first time. Dear Isabelle, welcome back at home. It is a real pleasure and honor for us to host the two of you tonight.
Well, thank you very much from my side as well for being with us. It's a great honor for me to do a brief introduction. Professor Mahé, as Gunnar alluded to, is a professor of internal medicine in Paris Cité and head of the Department of Internal Medicine at the Hôpital Louis Mourier, and past president of the Scientific Council of the French INNOVTE VTE network. And she's principal investigator of the APICAT trial, which indeed has become the largest randomized trial ever performed in cancer-associated thrombosis, comparing a reduced dose of apixaban to full dose apixaban for extended treatment in patients with cancer-associated thrombosis. Professor Couturaud is Professor of Respiratory Medicine at the Brest University and head of the Respiratory Medicine Department in Brest, France, and director of the research unit INSERM program, and there directs the investigation network on VTE, so the INNOVTE network. And he's PI of the RENOVE study, which compared reduced dose to standard dose DOAC in patients with VTE without cancer. So we're very happy to hear from the both of you on the two studies and have some discussion on that.
Thank you very much for inviting me to present the results of this trial, which was performed on behalf of my colleagues of the INNOVTE network. Here are my disclosures. And so why did we this study? In patients with venous thromboembolism at risk of recurrence, where extended treatment with DOACs has been indicated, the optimal dose is still unknown, was still unknown. In the Amplify extension and Einstein choice studies, extended reduced dose apixaban or rivaroxaban appeared as effective as and possibly safer than full dose. And guidelines suggest or recommend to consider the use of reduced dose DOAC over full dose in patients offered extended anticoagulation. But these two studies were not designed and not powered to demonstrate similar efficacy and improve safety with the reduced dose. With the inclusion of placebo or aspirin control groups, they enrolled patients with uncertain need for extended anticoagulation and consequently strong evidence for recommending reduced over full dose DOAC in patients in whom extended treatment has been indicated was lacking. So the study was published some months ago in The Lancet. The primary objective was to demonstrate non-inferiority of extended anticoagulation with reduced dose DOAC versus full dose DOAC for the prevention of recurrent venous thromboembolism. And using a hierarchical testing procedure, key secondary objective, if the main was verified, was to demonstrate the superiority of reduced dose DOAC over full dose on major or clinically relevant non-major bleeding, and if confirmed, on the composite of recurrent venous thromboembolism or clinically relevant bleeding. It was an academic, multi-center, randomized open-blinded endpoint probe trial, and randomization was stratified by center, DOAC type, and antiplatelet use. And after completing six to 24 months of anticoagulation, patients at high risk of recurrence were randomized to continue with the full dose apixaban or rivaroxaban or low dose apixaban or rivaroxaban during a median follow-up of 24 months. Regarding the sample size, it is important to understand this point. Regarding the primary hypothesis for non-inferiority, we expected a 2% risk of recurrence per year based on the Einstein choice and amplified extension trial, with 90% power to exclude a hazard ratio of 1.7. And regarding the key superiority hypothesis, we expected a 35% reduction on bleeding, and therefore 2,200 patients were required with a 24-month median follow-up. But during the study conduction, we observed a much lower risk of recurrence than anticipated. And then we increased the sample size up to 2,774 patients, and we increased the follow-up of patients in the study at 30-month median follow-up. And here is the flow chart. So what is important is that the patients were followed up between 0 to 5 years according to the time of the inclusion in the study. When they were included in the study, they remain included in the study until the last patients included in the study had a minimal follow-up of 1 year. It is why we have this range between 0 to 5 years of follow-up with the median follow-up of 36 months. And what is important is that during these 30 months of follow-up, median follow-up, we had only 2% of loss to follow-up. Regarding a study population characteristic, what is important is that most of venous thromboembolism were pulmonary embolism in 85% of cases, which was a pulmonary embolism at intermediate, high, or high risk of death in about 20%. Otherwise, 1/3 had a family history of venous thromboembolism, and 30% had a BMI higher than 30. The second very important point is that most of the patients were included for unprovoked venous thromboembolism. It was a first unprovoked venous thromboembolism in 60% of cases, and patients were included after a second or third unprovoked venous thromboembolism in 1/3 of cases. And third point is that 30% of patients were considered at high risk of bleeding according to the VTE bleed score derived by Eric Klock. Now, regarding the results, the 5-year cumulative incidence rates of symptomatic recurrent venous thromboembolism occurred in 1.8% in the full dose group and 2.2% in the reduced dose group. There were similar rates of recurrent PE or fatal PE. There were a difference regarding isolated proximal deep vein thromboembolism. The hazard ratio was 1.32, with the upper limit higher than 1.7, and therefore the p-value for non-inferiority was not significant. It is very important to understand that the annual incidence rate observed in this study was fourfold lower than expected, with a very small absolute difference between the two groups. Here are the Kaplan-Meier estimates, and you can see that the curves are really confounding over all the study conduction. Then, regarding key secondary outcomes, bleeding, clinically relevant bleeding occurred in 50% in the full dose and about 10% in the reduced dose, yielding 39% risk reduction. And the risk reduction was even higher with major bleeding, 60% risk reduction. And consequently, there were a reduction of 33% in the composite of recurrent venous thromboembolism or clinically relevant bleeding. Here are the curves with the same graduation than the curves on recurrent venous thromboembolism. And you can see that there is a strong reduction in the risk of bleeding all over the follow-up and during all the follow-up in the study. And these decrease in the risk of bleeding was even higher at the end of the study. And here is the reduction in the composite of recurrent venous thromboembolism or clinically relevant bleeding. Lastly, all-cause deaths were similar between the two groups, and the occurrence, the frequency of arterial cardiovascular events was also similar between the two groups. In conclusion, there are 3 points. Regarding the statistician point of view, the DOAC dose reduction in patients with venous thromboembolism needing extended anticoagulation did not meet the study non-inferiority criteria. But regarding the clinicians, the physicians, the 5-year cumulative incidence rates of 2% of recurrent venous thromboembolism are low and reassuring in the two groups, in the reduced and the full dose groups. And in the reduced group, clinically relevant bleeding was reduced by 39%, and the composite of recurrent or clinically relevant bleeding by 33%. And this did not appear to be offset by an increased risk of death or arterial thromboembolic events. Lastly, there is a third point of view. This is the patients, and I see every week at a consultation in my hospital. These results will enrich shared decision-making process because you will have patients who do not want to have any risk for recurrence. They are for 4 years, for example, on full dose DOACs, and they prefer to stay on full dose. And you have otherwise the majority of patients who are agreed to stay on anticoagulant therapy, but they would like to avoid the risk of bleeding, and they are happy to reduce the dose. And here it is just the slide to thank all the participants in this study, and also to thank the patients. Thank you very much for your attention.
Well, thank you so much, Professor Couturaud. Great presentation, and the trial is so important, as you said already, also for our daily practice. Looking at the Kaplan-Meier curves, they seem to more or less superimpose, and as you said, the difference is small, although the non-inferiority margin wasn't perfectly met. What do you think will help us in that individualized decision? In your manuscript, you wrote that genetic testing wasn't mandatory, if I recall correctly, that you had probably few factor 5 mutation testing. In Germany, this is usually the way that it works. People go to a hematologist and get all these factors tested, and they come up with a couple of more or less clinical significant heterozygous abnormalities, let's call it that way, and then they are put on full dose anticoagulant lifelong, VKA sometimes even. So I think we should get away from there. That's my personal opinion, but how do you see that?
It is an important question. So it was not mandatory in the study to perform thrombophilia testing. This was done in about 35% of patients. And on this subgroup, there was no impact of thrombophilia. Particularly, there was no signal of reduced efficacy of reduced dose in patients with we term major thrombophilia. I mean deficiency in protein C, protein S, or antithrombin deficiency. There is no signal of a loss in efficacy. So we can conclude definitely, and we will see how we can get some information in the future on the patients in this study. But at this time, there is no signal that we have a reduction in efficacy of low-dose anticoagulant in patients with thrombophilia. Of course, patients with antiphospholipid antibodies were almost excluded from the study.
So would you say, by and large, you would opt more for a reduced dose because the bleeding signal is so strong? I mean, the longer we get away from the initial event, obviously, the less the VTE risk drops and the bleeding risk will stay high. Is that how you do it in clinical practice?
Yes, today I put lots of patients on the reduced dose. We call the patients. We have calls from patients to do that. But I think we need more information because there is non-inferiority, which means that we cannot exclude, even small, a loss in efficacy, probably in some subgroups of patients. And I didn't put here on my slides, but we have at least one signal that I presented in the ISTH Congress. In patients with BMI higher than 30, there is a signal of a loss in efficacy. The hazard ratio for recurrence on the reduced dose was 6.7, with a lower limit of the interval of 0.99. So it is not truly significant, but there is a strong signal that maybe in obese patients, we should not reduce the dose. What I presented is that there is a tendency of a dose effect response. And I would say today, at least in patients with BMI of 40 or higher, we should not reduce the dose. If we know that for the initial treatment, we could use DOACs probably, but for the extended phase, we should not reduce the dose. But now I don't have the optimal cutoff. I would say I think to not reduce the dose at 35 of BMI. At least it is what we showed during the Congress.
Another question surely comes, so what do we do with people who have atherosclerotic cardiovascular disease? Because we learned in the last years and we told our colleagues that we should not combine full dose DOAC treatment and aspirin or even other platelet inhibitors. Now here come the low dose DOACs, and I guess we are somewhat lost what to recommend people who have stable coronary artery disease and venous thromboembolism. In your study, the number of people who had aspirin was quite low, if I remember that correctly. So how would you recommend us to do if we reduce the dosage?
And I will respond, but if I continue on BMI, there is also a second signal. It is an increased risk of arterial event in these patients. And so we can see that at least the full dose is probably better than reduced dose because also the impact on bleeding is not significant in these patients. So there is clearly no real benefit on hemorrhage, and it is offset also by an increased risk of recurrent venous thromboembolism and arterial event. So from a general point of view, I think for the cardiologist, if they think that antiplatelets are very important for these patients, for the coronary artery disease, they have to keep aspirin, and they can lower the dose, they can reduce the dose of DOAC without strong concern, I would say. I don't know in obese patients how to do that, but overall, I think given the high level of evidence we have with antiplatelets in patients with coronary heart disease, I would say that probably the best option is to keep antiplatelet therapy and to reduce the dose. But we have to discuss with the cardiologist at each time we have patients like that, because it is complex situation sometimes according to the type of stent, etc., the time where the stent was put, etc.
And one other question, looking at your baseline characteristics, I found that many more patients had pulmonary embolism at baseline compared to isolated deep vein thrombosis, whereas in many other studies, it's rather 50-50 or something like that. Is this because people are more afraid to stop anticoagulation or vice versa, are more eager to continue anticoagulation, and therefore you find more people with pulmonary embolism?
It's a good point. I think it could be an explanation that in the Amplify extension trial and INSERM trial, I think in Amplify extension, it was 2/3 of DVT and 1/3 of PE, and it was 50-50 in INSERM choice. And in these trials, physicians were not certain if we should continue or not treatment. In our study, the very important point is that physicians were convinced that we should continue treatment. And also patients were agreed to continue treatment. So it is one of the explanation, and otherwise it is that mainly recruitment was done in hospital, and today we see more PE patients than DVT patients. So there is here clearly the recruitment bias from hospital setting. But I think it is a very interesting point is that in patients with DVT, physicians are almost more prompt to discontinue treatment, and probably patients are less anxious to stop treatment.
And one other question would be, I found that more people had rivaroxaban at baseline or during the trial actually than apixaban. Here in Germany, Stefan, I'm not quite sure, but I think apixaban is the leading DOAC. So are there more people on rivaroxaban in France compared to apixaban? And then surely going back to the ISDH convention where you also presented your study, we found this amazing COBRA study, not yet published, but presented, which clearly showed that apparently there's much less bleeding with apixaban compared to rivaroxaban. When looking at your trial, there were no substantial differences between the two. Surely you did not randomize for the drug, but you randomized for low dose versus standard dose. But would rivaroxaban be a more common drug in France maybe than in Germany for the time being?
No, I think it's a relative. It's almost 50-50 in France. So we will send a new abstract for another congress comparing apixaban and rivaroxaban, and I can't reveal all the results. But what is true, according to our subgroup analysis, is that the reduction on bleeding was the same on rivaroxaban and on apixaban, and the absolute rates of recurrence or bleeding were similar between the two groups. So now we are working on the two groups because patients on rivaroxaban and apixaban may be slightly different. And so we are analyzing that truly. But I would say for the COBRA study, what appears evident, and it's surprising to see that after 12 years, is that the first 3 weeks of higher dose of rivaroxaban was probably a mistake. When we look at the curves of the COBRA study, after 25 days, the curves are almost parallel, in fact. So the difference is clearly during the first 3 weeks. And what would be exciting if if we can demonstrate that after the first 3 or 6 months of treatment, probably there is no difference between rivaroxaban and apixaban. It would be at least very great to demonstrate that. And also it will provide also an additional indirect explanation that the first 3 weeks on rivaroxaban at high dose was probably was a mistake. In fact, I think it was too much. So at this stage, it seems that we don't have any difference between the two drugs, but we need additional analysis that we will publish in the months. It is ongoing.
Great. So I have to ask you one more question before switching the mic back to Stefan. Surely I'm the kidney doctor here. So what to do with people with severely impaired kidney function? In both your trials, you excluded people with creatinine clearance below 25, but surely we see these people in clinical practice. Surely we are even now reluctant to go with full dose DOAC. What would you recommend to us as nephrologists for people with deep vein thrombosis or pulmonary embolism after, say, 3 months of treatment? How shall we proceed?
Clearly, we have two people that greatly benefited from the reduction of dose. Older patients after 65 and even more after 75 years. And the second population clearly are patients with renal impairment. And there is such as a dose effect response, in fact. And so today, clearly, in patients with creatinine clearance below 50, for example, clearly we should reduce the dose. And maybe we can go for DOACs at low dose for creatinine of 25 or 30, but maybe a little bit lower. Probably in your practice, you try to for some patients, it's so much comfortable to be on this therapy rather than vitamin K antagonist. And so here, I think, I don't know if we will do a dedicated publication of that, but on the appendix in the publication, there is the results on the subgroups, and there is a tendency of a dose effect response.
Well, this was really good. That was the two things I was wondering about. I think we'll be having to look into the future for more of these sub-analyses, especially considering age and renal function, and maybe figure out some formula when to use which dose and or substance also, because there might be a difference in half-life of the two, and the once daily dosing and it's twice daily dosing. And in spite of all these data, some maybe may not be solved yet. Speaking of data, I would now maybe take the chance and move the discussion over to similar question, but in cancer-associated thrombosis, really the very comparable clinical setting. And I'm looking forward to Professor Mahé, who will give a short introduction slide set on this topic, apixaban in cancer-associated thrombosis. We're very much looking forward to that, and maybe we can have some discussion on the one or the two studies and at the end then. So please, I'm looking forward to your presentation, Isabelle.
Thank you once again for inviting me to discuss with you the results of the APICAT study that were presented during the ACC meeting in Chicago at the end of March this year, and simultaneously published in the New England Journal of Medicine. My disclosures. So a few words about the context of the study and the context of patients with cancer-associated thrombosis, because it is an evolving issue. And very briefly, you all know that patients with cancer-associated thrombosis have a life expectancy reaching many months and years nowadays. And what about the course of this disease in those patients? We know that the risk of recurrent VTE is very high soon after the VTE occurrence, but this risk declines over time, whereas the risk of bleeding remains substantial. In this context, international guidelines suggest continuing anticoagulant therapy for as long as cancer is active or anti-cancer treatment is ongoing. However, the optimal dose regimen in those patients, especially beyond 6 months, remains unknown due to the lack of data from prospective randomized controlled trial. So in this context, we hypothesize that the use of a reduced dose of anticoagulant could be as effective as and safer than a full dose for extended VTE treatment. To address this unmet need, it was an investigator-sponsored study. We designed the APICAT study. It was an international prospective randomized double-blind study, including patients with active cancer, completing at least 6 months of anticoagulant, and they were randomized in 2 different arms the full dose arm, apixaban 5 milligrams twice daily, and we tested the dose reduction. The second arm was apixaban at a reduced dose, 2.5 milligrams twice daily, for an overall 12 months follow-up duration. It's important to note that the recruitment was stratified according to both the site of cancer, breast, prostate, colorectal, or lung cancer, the most frequently encountered site of cancer in extended treatment, and also according to index VTE. The primary objective was to determine in a hierarchical test procedure whether a reduced dose of apixaban first was non-inferior to a full dose of apixaban for preventing the occurrence of recurrent VTE, and the second step, in case of success of the first analysis, the second step, the second objective was to test whether reduced dose was superior to a full dose for the occurrence of clinically relevant bleeding. On this slide, you have the explanation, the detail of the hierarchical procedure. The explanation is very easy to understand. At the end, we want to reduce the risk of bleeding in our patients with CAD, because those patients will know that are at risk of recurrence, but also are at risk of bleeding. That's the reason why we test the dose reduction, but we don't want to reduce the risk of bleeding at the cost of an excess of VT recurrence. Our priority is to be sure that when reducing the dose, this dose reduction is not associated with an excess of VT recurrence. And if we are sure of that, then in the second step, we test the dose reduction on the safety criteria. The primary outcome was the adjudicated recurrent VTE, composite of recurrent symptomatic VTE, incidental VTE, and VTE-related deaths. And the key secondary outcome was adjudicated clinically relevant bleeding, composite of major bleeding and clinically relevant non-major bleeding. We estimated that at least 1,722 patients would be required to be able to conclude for both primary and key secondary outcomes. We performed a time to event analysis using a fine and grain model and taking into account the risk of the competing risk of death for both intention to treat and per protocol populations. On this slide, you can appreciate the recruitment worldwide, and it was a difficult period, as you know. It was a pandemic, and the enrollment started in October 2018 until September 2023, with then still 12 additional months of follow-up. The recruitment was performed in 11 countries, 10 European countries and Canada, in 121 centers, and overall 1,766 patients were randomized. On this slide, you can appreciate the different repartition of the two groups. On the left, 866 patients were assigned to the reduced dose apixaban, while 900 were assigned to the full dose apixaban. Of note, only 3 patients were lost to follow-up during this study. It's a very low number of patients who were lost to follow-up. And the second point I would draw your attention on is that a high proportion of patients that could be analyzed in the per protocol populations, more than 80% of patients, so that it's very important that can confirm our results in the first ITT analysis, in the second step in the per protocol analysis. Here are the characteristics of our patients. They are representative of the population usually encountered in usual practice with cancer-associated thrombosis at receiving extended treatment. Mean age 67 years. Only 13% of patients with moderate renal impairment. A majority of patients with the index event as PE. And as I mentioned before, we are not surprised to see that the most frequently recruited site of cancer were breast, colorectal, lung, and prostate. Of note, 2/3 of patients were at the metastatic stage. You can see that the median time 6 index events was 8 months, and that the median duration of the study drug was almost 12 months. Here are the results of the primary outcome. It was an efficacy outcome composite of recurrent, symptomatic, or incidental VTE. You can see that the risk of VTE recurrence was quite low in both groups, 2.1% and 2.8% is a reduced dose and full dose respectively. So it means that the non-inferiority is reached in this analysis. And here, as in figure, in the second layer figure, we can see that at any time there is no idea, no possibilities that the reduced dose is associated with an excess of VT recurrence. So it is very reassuring that the reduced dose is not associated with any excess risk of VTE recurrence. What are those recurrences? A majority of symptomatic events in both groups with both VE recurrences and DVT recurrences. As we reach the primary objective, the primary efficacy objective was reached, we are allowed to move to the secondary objective, the safety objective. And here we can see very clearly that the risk of clinically relevant bleeding is significantly reduced, significantly less in the reduced dose as compared to the full dose, with the 12 months cumulative incidence of 12.1% versus 15.6%, meaning a 25% reduction in the risk of clinically relevant bleeding. What are those bleedings? It's important to see that both the risk of both major bleeding and clinically relevant non-major bleeding is reduced with the reduced dose apixaban as compared to the full dose. It's not only the risk of clinically relevant bleeding is reduced, but not only thanks to a reduced risk of clinically relevant non-major bleeding, but also a reduction of the risk of major bleeding, which is, as you know, the most relevant. That's what we can appreciate here on this slide. It's very impressive that soon after the apixaban dose reduction, the risk of major bleeding is reduced in the reduced dose apixaban. What about death? The risk of death is not different according between two groups, less than 20% in both groups. It illustrates that in patients surviving at least 6 months after the occurrence of the index event in patients with cancer, in those patients still alive at 6 months, the prognosis is quite good, with less 20% risk of death after 12 months of follow-up. This slide represents the subgroup analysis according to the index VTE, according to the primary tumor site. It was stratified, as you know, and according to patients' characteristics, age, gender, and renal impairment. And whatever the analysis you are looking at, there is no difference, so no tendency to a difference of the treatment effect in terms of efficacy and bleeding across the different subgroups. So we conclude that in patients with active cancer who have completed at least 6 months of anticoagulant treatment, extended anticoagulant treatment with with reduced dose apixaban was non-inferior to the full dose to prevent recurrent VTE, and that this reduced dose additionally resulted in a lower incidence of clinically relevant bleeding. So we suggest that those patients might be eligible to receive a reduced dose of apixaban for extended treatment. I'd like to thank all the investigators and committee members who were involved in the study. It was a lot of work, of course, and involvement of all those people was very important to result in the publication that you could read in the New England Journal of Medicine.
Thanks so much, Isabelle. And we were really thrilled to read your paper. And we had you 2 years ago already as a guest here because we wanted you to introduce the topic to us. So my first question actually is, why are you so great in France to conduct all these studies? And I saw your map, and there was, well, right in the middle in Germany, nobody participating while you are doing all these studies. And this is not the end of the story. You are doing the bad VTE trial with Laurent Bertoletti and Saint-Etienne. I just read that there will from Brest, from Martine Gillard, be the aquatic trial at the next ESC meeting on antithrombotic treatment. So are you just better connected between your centers, or how comes that you are able to do all these studies?
I would like to start with to answer why Germany was not part of the study, and then I move to the second question. So why, about Germany, it was not possible to initiate the study in Germany because the low dose was considered as a standard treatment, and authorities did not authorize that. We couldn't test the dose reduction because to me, in this study, as a rationals, the full dose is a standard treatment, is a control arm, and I test the dose reduction. And in your country, the reduced dose was still already considered as a reference.
Well, that's kind of an excuse for us anyway. Yeah? Great to know. Yeah?
You're right at the end. So, and the second part, I think Francis Couturaud is the director of our network. So we have a fantastic network, and yes, it's true. There is a connection and a real involvement in all investigators and centers involved in VTE. But additionally, in the APICAT study, we had also, I have to say that, the participation of colleagues involved in oncology. And it's an important point in oncology and supportive care. And that's the reason why I think that the relevance of result is very important, because we have the patients from very different management sites were included. But of course, the INNOVTE network is a fantastic network and explaining a lot of things.
So since you design all these studies together, how comes that in your study in APICAT, you included incidental VTE events as outcome events, whereas in the RENOVE study, it was only symptomatic? And did you do routine imaging or just in case of clinical need? Because I saw that people on the full dose actually had more rather than less VTE events found as incidental VTEs.
So the design was, it's not discussed together. The diseases are different. It's important to keep the disease in its respective context. So in the field of cancer-associated thrombosis, we consider that the occurrence of an incidental VTE has the same impact of on the prognosis of patients, and those events are considered as part of the primary endpoint. It was the case in the Caravaggio study and in all other study. And the part of, so it's considered because of the impact on prognosis as important to treat them in a similar way as symptomatic VTE. No systematic imaging, to respond to your question, only in case of symptom. But we have to acknowledge that in patients with cancer, they have very frequent imaging for cancer staging. And we cannot exclude that it can explain that some incidental PE could be diagnosed thanks to an imaging performed for cancer management, but not more in one arm as in compared to another one, because the characteristics of patients and sites of cancer were quite similar in both arms. So I don't think it is an explanation.
But maybe they had more bleeding in the full dose, so maybe in order to search the source of the bleeding. So one more question to the study specifically. When looking at your baseline data, again, quite a lot of people had low molecular weight heparin before being randomized into one of the two arms. I guess that's because you started the study quite a lot of years ago, and this would no longer be the case nowadays. You would start with DOACs regularly in CAT, wouldn't you?
Yes. So it can be an explanation. The study, the recruitment started in 2018. It is, you're right. So it's true that at that time, the use of heparins was the rule for the first 6 months. And after the publication of the Caravaggio study, the use of DOACs was growing, but especially in specialists of VTE, because oncologists preferred continuing low molecular heparin. So, and additionally, we had a lot of discussion about patients with gastrointestinal cancer. It was not with many discussions. So I think that this use of low molecular heparins before randomization illustrates and was very representative at the practices at that time. Maybe it would be different now with more DOACs before randomization. But we tested the treatment before inclusion, and it didn't impact results on both endpoints.
Yeah, and Stefan, if I may, I would have two final questions from my part. So the first would be, when discussing CAT here at Marcus at Home for the first time with Laurent Bertoletti, I guess 3 years ago, there was much enthusiasm with regard to anti-11 inhibitors. And you are, I guess, also all participating in the ASTER and MANULA studies.
Yes.
We saw in atrial fibrillation kind of a disappointment in the last 1 or 2 years. So what is your idea on factor 11 inhibitors in 2025, still surely conducting all these trials? And the last question from my part would be this general rule that people with active cancer need anticoagulation as long as their cancer is well active. Is this really still valid nowadays with all this novel treatment, with much longer survival of people with cancer? Or might, in at least some people with cancer after a couple of years, be there a point where maybe we can also stop anticoagulation?
Two difficult questions. So about the anti-11.
That's why we ask you, because you are the leading expert, yeah?
So, well, about anti-11, so it's a very attractive class of anticoagulants. It's difficult to anticipate before a clinical trial is performed the results that will come. We are all surprised. One drug is successful, another one is associated with an excess of bleeding. So it depends on the context. I think that we have to wait for the results. A good point for abelacimab in ASTER and MANULA is that the study is continuing. So it's for me, it's a good point. If there would have been an excess of recurrence or bleeding, I suppose that the study would have been stopped. So the recruitment is continuing, and is very soon will be very soon completed, if I'm not wrong, in a couple of months, but it's going well. So we have to wait. If we have another option for treating our patients, it will be great, I think. We have subcutaneous route. We have also oral route. If we have now another way to treat our patient with an injection per month, it's fantastic. So we have to wait. And about the possibility to stop treatment, you're right. So it's a question that I'm asked very often with the results of APICAT. And I have to say that the concept of active cancer has probably to be revised, because it involves a very heterogeneous population, different stages of cancer, different anti-cancer treatment, and patients with metastatic cancer could have a very chronic disease, a very stable disease, and could have a progression of the disease. So we are doing further analysis to try to assess if there are different profiles of patients. But however, with both regimens, full dose and reduced dose, we have to see, we saw that the risk of recurrence is low, very low, lower than expected. So we are successful with both dosage to prevent the risk of recurrence. If some patients could be stopped, remains to be determined. We have to do another study, and the question is probably most relevant in patients with breast cancer. We are analyzing this population because recruitment was stratified according to site of cancer, when we have a very large strata with breast cancer.
Well, Gunnar, you started off and took almost all important questions, I think, on the one hand. On the other hand, there'll probably be plenty of more. I dare to pose two more short questions before we have to come to an end of this very, very interesting discussion. One is quality of life. Did you see any differences in quality of life? Because that's important for cancer patients nowadays, particularly in the two study arms. And the other one is, you might have mentioned, I might have missed it, which is the sites of cancer that you excluded in your study, and would they be, as we discussed earlier in the other discussion, to put patients into the one or other treatment group? Is there cancers, pancreatic cancer, prostate cancer, that we would particularly treat with high or low dose anticoagulant?
So about quality of life, we didn't test it or assessed it, because patients were receiving exactly the same drug package. So two pills in the morning, 2 pills in the evening. So no difference was expected from the way of taking treatment.
To make that more concrete, the question obviously is, if you suffer from a minor DVT without a large pulmonary embolism, what's worse? I mean, suffering from
the index
more or less
VTE.
severe bleeding, or a more or less severe
Yes.
VTE. If death is the same, the two groups.
Yes, but we didn't assess quality of life in this study. So
okay,
we could have patients with cancer, so we didn't. Patients with intracranial tumor, known intracranial tumor, were not included at the beginning. But in case of brain metastasis or primary brain cancer, if such a metastasis or brain tumor was diagnosed during the follow-up, investigators could keep the patient in the study. So we have patients that will be analyzed with intracranial tumor. But it was the main exclusion criteria relative to tumor type in this study. We have also the patients with severe renal impairment. In the same way, patients could not be included in case of creatinine clearance less than 30, but in case of decreased creatinine clearance during the study, patients were kept in the study, not excluded because of this point. and we will conduct an analysis according to the evolution of creatinine clearance during follow-up. I'm sure you will be very interested in this analysis as a nephrologist.
So to take that from my nephrology partner, you wouldn't have had many patients who fulfilled two of the three dose reduction criteria of apixaban anyways. So that is HB above 80 and body weight below 60 and a high creatinine. I mean, looking at your baseline parameters, that would have been very, very few patients, wouldn't it?
So
very old, very underweight.
So dose reduction, according to 2 out of 3 criteria, is mostly for patients with atrial fibrillation. So
sure, yeah.
It's important, you're right, it's important to stress this point because we too often see patients with VTE in practice, where clinicians reduce the dose at soon after the PE diagnosis. It should not be the case. So it's very important to stress that the full dose, and in case of DOAC, a higher dose should be given in patients with 2 out of 3 criteria, of course, with a creatinine clearance higher than 30, but the dose adaptation with 2 out of 3 is not adapted, is not relevant in patients with VTE. Those patients should not receive a reduced dose according to this rule.
That's when I just may add this, is what I love about edoxaban as a nephrologist. So for people with creatinine clearance below, say, 30 or even below 50, actually, who have venous thromboembolism, I generally tend to use edoxaban where we are allowed to do this reduction, whereas we're not allowed to do this with apixaban and rivaroxaban.
You're right, but at the beginning you use low molecular heparin. The first days you don't reduce the dose. It's a week after, so it's important to remind it.
It's important to discuss this with you as experts because there really isn't much data, and as you said, there's a lot of uncertainty in general practitioners who don't know which dose to use, and we often find it difficult to do. So I think that the APICAT study, of course, in a particular situation with cancer patients, but this has really shed a lot of light into these uncertainties and given us some more possibilities in the long run of treatment. And the long run, again, I mean, from a cardiology point of view, we're seeing these patients for cardiac surveillance because they, as Gurun said, the cancer stays on oftentimes for many years. People don't die of their cancer, so the question becomes more and more important, and obviously the bleeding risk does. So very, very important. Gunnar, if there's no more questions from your side.
We could continue for hours, but we do not want to overstretch your patient because we want to have you back.
So thank you so much, the two of you, for these excellent presentations, your wonderful work, the 2 great studies, your discussion with us. Thank you so much. Hoping to see some more data in the future. Maybe have the opportunity to hear and see you here on our channel. I just learned that the ISTH will take place in Paris next year.
Yeah.
So maybe we get the opportunity to see each other there. Who knows? Well, thank you very much again for your time.
Thank you.
Thank you.
Thank you for
too.
inviting us. Thank you.